Oh, I don't think it's the full screen on the bottom, Anna.
I try to
Oi,
find.
pessoal, bom
Yeah,
dia.
bom dia. It's not that compartilhar, it's in the bottom with the, yeah, there you go. Beautiful.
Yeah, you can see.
Yes.
Whenever you're ready. Oh, no. Well, and I'm Liana, and this is my first presentation in English, and so please forgive me in lack of fluency. I'm PhD and study at Federal University of Maranhão in the Public Health Program. So, early growth surveillance is crucial for identifying adverse trajectory preterm and small gestational age children. Catch-up growth plays a key role in reducing perinatal risks and prevents long-term neurocognitive and metabolic problems. This process is influenced by biological, maternal, and socioeconomic factors. Uh, Fetal active ketchup growth within the first 1,000 days is linked to higher risk for persistence growth deficits, especially in environments with fewer resources. So the gap in researchers. So early identification of children at the risk of failing catch-up growth remains limited, particularly in the low and middle income settings. Index context, structural and intimacy ratio inequalities amplify early life risks. Current evidence shows a critical gap. A lack of models specifically address fairing the catch-up growth, limited incorporation of an inquiry perspective, and the most models worry developments focus on rapid gain, in childhood obesity, and linear growth factoring. Your objectives is development a machine learning model to predict fairy in HKTP API growth to 2 years using an equity informed approach. And the data coming from the Brisa cohort in two cities, São Luís and Ribeirão Preto, collected in the baseline at bird and again and 2 years follow-up. Initial the sample for your study and you chose children and classified the preterm or small for gestational age. Your outcome is necessary to activate happy grow by 2 years of age. Definitely is a wait for age Z score below to 0.67 point at 12 months. And final sample uh, 580 children. In the predictors you chose, you building conception from your work. The predictors such as social demographic, including maternal age, marital status, children's rates or ethnicity, prenatal care, prenatal visits, location of prenatal, behavior and maternal health, alcohol, smoking during pregnancy, facility activity, in number of maternal comorbidities, um, birth characteristics such as sex, mode of delivery, degree of prematurity, and the first years of life of the children. We collect exclusive breastfeeding, history of hospitalization, presentation of health conditions such as allergical, urinary, and gastrointestinal disorders, numbers of vaccines administered up to 6 months age. So, using the modeling pipeline was building using the tire models from your work, follow the machine learning's triple IA report guidelines. Initial the data set was randomly divided in 6 turns into training and testing. And the models were developing using 5-fold validation. The predictive was improving through the feature selection using Boruta algorithm, and avoid the detection applying in the training data set. After 100 interactions, 80 variables were selected for Boruta for the next analysis. Maternal age, maternal race, years of education mother, diabetes status, household density, number of prenatal visits, level of prematurity, and the child electric conditions, while the predictors using the models. In the pre-processing steps including the missing data imputation, collinearity removal, Fury scaling, dummy variable encoding, and zero variance filtering. And 6 models were evaluating random forest, logistic regressions, XGBoost, naive Bayes, SVM, and decision tree. The model Tony was performed using grid search across the 15 hyperparameters combination. The evaluation models using asset metrics such as curve AUC, as the primary outcome for selection. Others metrics such as accuracy, specificity, F1 score, and the model interpreted was using the Shapley additive explanation values to assess predictors' importance. This is resulting in the sex machine learning algorithms in training set. The models, the best Rocky AUC was random forest, follow the logistic regressions in the training set, and sensitivity. The random forest is 0.88, follow the logistic regressions 0.87. See SVM active 100 for specificity. SVM 0, random forest 0.57, and logistic regression 0.73. For the text data set, you chose two models, random forests and logistic regressions. For the model you chose for random forest model with the AUC 7 point, we call the for diagnostic testing clinical practice, and the accuracy 0.744, comparable others models, what the models prediction of accelerating weight gain, postnatal growth failure, and linear growth delay. It ranges from 0.669 to 0.78. And the chart summary plot of the weight most important features for the random forest model. The level prematurity is the strongest predictors, and the risks and moderate preterm, very preterm at risk, and extremely preterm. Race no white maternal increase the risk. Maternal diabetes, chronic rouse wounds, and for the outside, higher education and more prenatal visits. That's degree risk. In the results, no white maternal race, maternal diabetes in crowded households, reflects concentration in maternal capital and the cumulative impact of structural inequalities. Maternal racism and persistence of racial inequalities was determinant whose effects extend beyond birth. Em outros Brazilian courses, maternal skin color function was a marker of systemic vulnerability, and this model supports fairness models by improving detection in vulnerable groups. And the racism no white is not implying biological causing. And implication, your models can use it for intensify surveillance in primary care, supports targeting interventions in the first 1,000 days, and potential for scaling to low resource settings. And the conclusion, the studies advancing in child growth surveillance by showing that your theory of catch-up weight can be predicted through equally forming modeling approaches by integrating biological vulnerabilities and social determinants. The proposed algorithm enhances the ability to address inequality in child health and defines aligns the global health and the nutritional agenda, strengthening efforts to reduce disparities in early childhood growth outcomes. And thank you for attention.
Awesome. Thanks so much, Anna. As I mentioned, if anyone has any comments, you can share in the chat or feel free to unmute with comments or questions for Anna and the team. I see Erica is here, maybe some others. Any questions or comments this morning?
Anna, congrats on the presentation. Thank you for bringing this important topic and showing us the approach with machine learning. I wonder, do you think that this would be a model that would be used at the basic health unit, or would this be used in a more specialized clinical setting?
I think using in the primary care for the predictions was easy collections, prediction such maternal raising, it's easy collections. I think the prediction word collections is the level of prematurity.
I see. And you told us that the sample came from a few different cohort studies. Do you think that the primary care setting, you would be able to go back and get the information from the patient all the way from birth as well? Or would you need to link this to other data systems at this moment?
Sorry, can you speak slowly?
Sure,
My
sure.
English is not fluent.
I'm gonna ask in Portuguese, folks, and I'll translate in a second. Ana, eu vou falar em português, depois eu traduzo, tá?
Obrigada.
A minha pergunta foi se parece que você usou dados de algumas coortes, então você tinha o dado desde o paciente, né, do nascimento e tudo mais, até antes do nascimento. Atualmente, se a gente for colocar essa predição na UBS ou no cuidado primário, você conseguiria puxar essa informação dos pacientes que estão ali, ou isso ainda não é possível?
Vou falar em português, fica
Tá,
mais
pode falar,
fácil.
depois eu traduzo.
Então, esses dados são de fácil coleta na atenção primária. Eu acho que a informação mais difícil seria a idade gestacional que aquela criança nasceu, né? Então, a gente teria um pouco mais de dificuldade para saber quantas semanas aquela criança nasceu.
Entendi.
Para aplicá-lo nesse contexto, ou teria que vir da caderneta da criança, ou a mãe lembrar. Mas quando a gente escolheu os preditores, foi mais nesse sentido de escolher os preditores que fossem de fácil coleta na atenção primária.
Tá certo. Vou traduzir então. So, folks, I asked Anna if this model could be used in the primary setting, especially on the data that is available, because on her study, she used data from a few different cohort studies. She responded that most of the data that is used in the model is actually quite easy to collect in the primary setting and would be available there. The most challenging piece would be on the gestational age piece, because that would not either be collected or would rely on the recollection of the mother, or having this data available to make the prediction. Thank you, Anna.
Yeah, I had a similar question, which I just dropped in the chat, which I'm always curious when people do secondary data analysis. What kind of important variables did you find were missing that you really wish you could have included in this kind of analysis? Maybe other than what you've already referenced. Of course, quality, like what you mentioned with gestational age, is always a challenge, but anything that maybe was very missing or altogether missing from these data sets. Ana or Erica?
Ana, quer que eu traduza?
Sim,
Tá. Então, a Ashley perguntou sobre, no geral, com os problemas de dados secundários, assim, ainda que esse seja um estudo de coorte, né, então a qualidade dos dados vai ser melhor. Ela perguntou se você encontrou dificuldades com dados que não foram coletados ou variáveis específicas que você gostaria de ter para fazer a modelagem e não estavam disponíveis.
eu acho que a própria coorte, ela tem muitas perguntas que elas são muito relacionadas aos sistemas de informação que já são coletados. Então, a gente não teve dificuldade dessas variáveis, mas a gente teve dificuldade em relação à coleta, o preenchimento desses dados disponíveis quando foram coletados. Esses dados são de 2010, que é da Corte de Nascimento. Hoje as crianças elas estão na fase não é nem adolescência, da fase escolar.
Entendi. E aí você está dizendo que a parte das crianças, por exemplo, você não tinha o dado completo delas, é isso?
Isso, por exemplo, dados do nascimento, o peso, por algum motivo, não foi registrado. Então, a gente não pôde calcular a falha no catch-up.
Tá certo.
So I'm saying the variables exist, the cohort is well built, but so that's really good. But the challenge is the actual collection or the filling out of the data. Sometimes it's unavailable, as we know in these things, that sometimes that happens. And this is from, did you say 2010? Yeah. So, these children who were infants at the time are now adolescents. So it's not even such that we can go back and ask again in many cases. I see Natan has a question. or comment?
Yes. So can you hear me?
Yes.
Okay. I'm gonna ask in Portuguese and then I'll translate. I think it's gonna be easier. Ana, parabéns pela apresentação, foi muito boa. Eu queria perguntar sobre a possibilidade, por exemplo, se vocês pensaram na possibilidade de fazer um modelo especificamente para as crianças que não tinham fatores de risco, porque vocês viram aí que há mães negras, ou então baixo peso ao nascer, prematuridade, mas eu também fico pensando se para um contexto clínico vocês pensariam em utilizar esses dados para poder predizer se crianças que tiveram condições de risco habitual durante a gestação e parto, se elas têm alguns fatores intrínsecos ou extrínsecos que poderiam também interferir nesse processo de desenvolvimento.
Tá, assim, a nossa grande dificuldade, que os dados da corte, elas são muito semelhantes para as crianças que tinham fatores de risco ou não. Especialmente no o catch-up growth, ele afeta essas crianças que já nascem em desvantagem. Por isso, a vulnerabilidade. Então, quando a gente tentou colocar outras crianças que não tinham essas condições, o modelo não ficava bom da performance.
Mas vocês chegaram, tipo, vocês juntaram as duas, mas vocês fizeram um modelo só para essas que tinham um parâmetro melhor?
Sim, sim. As
E os
crianças que não tinham condição com esse desfecho. Então, as métricas ficavam muito ruins. Tipo,
Entendi.
a curva ROC abaixo de 0,60.
Entendi. Obrigado, era isso mesmo. Let me translate now. I asked if they try to create a model for those that have like hapto risk, so those with white moms or that were at term, the right gestational age, right nutrition, breastfed, and they say that they did, and the parameters of the model and the accuracy and sensitivity, specificity were not good. So they kind of removed those because, of course, that when you have those parameters, it's very clear that the children will develop better. So I was wondering if any of factors those children might affect the growth even when they had like all great in the prenatal or delivery care. So that was what I asked.
Thanks. Anyone with maybe one more question or comment before we end? Or any final thoughts that you would like to add, Anna?